We'll start this first session. And so this was one of the case which was started as a routine case. But this complication is so common that even in simple cases, you can land up with this complication. And this is one of the nightmares in the cath lab, so we'll show the case. He's a 50-year-old male who presented with anterior wall ST elevation MI, and a primary PCI to LAD was planned. The circumflex also showed a tight stenosis, and there was a subtotal occlusion of the left anterior descending artery. Okay. So our workhorse BMW wire was placed into the LAD, and the lesion predilatation was done routinely with the 2O balloon at 12 ATM. On the left side, you can see the image after the balloon predilatation and intracoronary nitrates. So over here, the plan was to place two drug-eluting stents. For mid-LAD, by eyeballing, it was 2.75, and for the proximal LAD, it was 3O. The operator actually took, in this case, relatively larger diameter of the stents as compared to the visible appearance of the LAD. And you can see he put a 3x38 in the mid-LAD, followed by a 3.538 in the proximal LAD. And then for flaring of the overlap, same balloon was used to inflate at 16 ATM. And you can see in the third view, there appears a bit of overdilatation as well. After flaring, the patient collapsed within seconds, even before the operator could remove the stent balloon. There was hypotension, impaired mentation, along with bradycardia. And you can see there was, at the neck cine, there was a huge contrast spillage into the pericardial cavity, and this was a grade 3 frank perforation. Immediate fluid resuscitation, inotropic support, and pericardiocentesis was done. The patient also needed a few minutes of CPR as well on the table. So luckily the other views were not playing good, but this view is playing, and you can see there's a still grade 3 perforation, and this is after 2 minutes of CPR and 8 to 10 minutes of resuscitation. Autotransfusion of the blood was also used in this case, and the same stent balloon was, because it was still in the guide, that was re-advanced and that was kept there. So balloon tamponade was done at least for 20 minutes, but still there was pericardial leakage. So in order to address that, a 3.5 into 21 PK Papyrus was deployed at 12 ATM for 30 seconds. Then the balloon was deflated, and then it was re-inflated at 14 to 16 ATM for another 1 minute. The ACT was checked because it was around 270 first and then around 240 to 250. So no additional dose of heparin was given and no reversal was also done. And this was the result after placement of this covered stent. And you can see the perforation has been sealed. The patient's hemodynamics came back. You can see a good heart rate in this case, although the patient was still a bit apprehensive and short of breath as well due to the ischemia-induced and LV dysfunction, which was during the balloon tamponade, prolonged balloon tamponade. So regarding conclusions, quick identification is very, very important. And after high pressure NC or larger diameter balloons deployment at high pressure, you should always check before removing that balloon out of the guide. And pigtail insertion and autotransfusion in massive drainage, they are important steps. ACT of 200 to 250, while the equipment is still in there, ACT of 250 is at least is advisable. When you remove the equipment, you can bring it below 200. And adequate diameter covered stent of at least 1 to 1 should be used, and that should be deployed at a high pressure at the site of perforation, and the stent length should be adequate, that it should also cover the inlet. If there is a CTO, then we have to seal both the ends. And serial echo was done in this patient because he had severe pericardial pain as well. So addition of colchicine relieved his pain. DAPT adherence was continued for 1 year with 150 mg of aspirin and clopidogrel 75 mg and high dose of statin. So because this is almost 1 year old case, because we did follow up of this case recently in 1 or 2 weeks ago and did his echo. His ejection fraction is 45%. There is interval hypokinesis, but he does not have any later on chest pain or any ischemic symptom, because when you place a covered stent, you have to continue a longer term DAPT and you have to give good dose of statin and you have to keep a close follow-up as well. So any comments or questions, especially from the panel? No, we did not do a PCI to his circumflex later on. After close follow-up for the first 2 months, because the patient was not having any ischemic symptoms, so we discussed with the patient that your other vessel was not intervened because you had a catastrophe and we had to cover it with a special device. And because the patient was not having symptoms as well, so we actually ourselves did not offer him to do a PCI to circ as well.
Anjum, you did well, when you were faced with this nightmare. Now, can we have a little conversation between the panel of experts?
That's a great thing. But what I did not see in the pictures was a stent balloon tamponade. Did you do that? Because the patient collapsed, you did a 2-minute CPR, or basically an 8-minute resuscitation. But that's quite a long time for resuscitation. So the real, we've all been through this, right? Having done enough angioplasties. And the basic mistake was an overkill, basically, initially, to get a bigger balloon, bigger stent in. And there is always a safety check that you call post NC dilatation, that you pull the balloon back into the guide, but always take a check injection for this very reason, that do you have a perf or not, what kind of a perf is there, and then you can just go straight back in. So I guess, primary PCIs, everybody's in a bit of a rush, and you're not you are not perhaps held your cool, because the wire was out, the balloon was out, so that was the best thing to have saved him, and he had fits, so maybe everything came out. So stent balloon tamponade is really good, and I think the whatever they did was right, and they have to get the papyrus in. And the message is that you should not have a cath lab if you don't have a covered stent on the shelf.
The stent balloon tamponade was done immediately, and meanwhile the CPR was continued. And when we put in the I was sitting outside at the workstation, and when I came in, the patient neck veins were extremely engorged. So we immediately put this needle into the pericardium, and the blood came out with a gush. And within a few seconds, 20 to 30 seconds of the drainage, the patient's hemodynamics luckily came back. So then we intentionally did balloon tamponade with intermittent perfusion for at least more than 10 minutes. The reason was that this PK papyrus and other covered stents, the stock is limited. So we first always implement this balloon tamponade. Sometimes it's successful, but many times it's not successful. And moreover, because the primary labs, there are 2 primary labs inside the emergency floor, and there are 5 main cath labs. So we do not keep this stock of covered stents and other high-tech inventory in all the cath labs.
Dr. Anjum,
so sometimes you have to do immediate, balloon tamponade, and meanwhile you bring in the covered stent. Sometimes it seals, but many a times you have to put in it.
There's a higher risk of an intramyocardial segment perforating. So after you did pre-dilatation, did you check for any intramyocardial evidence?
Sorry, sir? After pre-dilatation? Pre-dilatation before stent placement?
Yes.
Yes, we did the pre-dilatation with 2.5, and those images are saved here. Unluckily, the videos are not playing. But at that time, there was a TIMI3 flow into the distal vessel, although the vessel diameter was not large, but there was no perforation or something.
And for the
And
benefit
even
of,
after the first stent, there was nothing bad, but after the second stent, before taking any view, so the patient collapsed.
and just for the benefit of any fellows here, why didn't you use protamine sulfate? Why should it not have been used? To reverse
Sorry, I
the
could not understand.
anticoagulation.
Why did not we use the protamine? This is the question. Okay. In this case, we checked the ACT. Initially, it was 270, and because all the equipment is still in there and the wire is still in there, we are doing balloon tamponade as well. If we reverse the ACT to below 200, there would be thrombus formation in the LAD, and that can be even more catastrophic. So that was the reason. If you have removed all the equipment and there is a minor perforation in the distal branch or something, then you can reverse the anticoagulation.
Professor, just a quick comment. I know this is a very panicky situation.
Yes.
But it's a good practice to, as you are tamponading with the balloon, just get the femoral access. Because to get the other guide up, the ping pong guide technique, wire it, and while you are, use the other guide to deliver your covered stand. That can save you the time, because if you take the balloon out and on the same wire you take the covered stand, in that period the patient is going to tamponade. So it's a good practice just to get the access down. You may not need it. You cannot, sometimes you can tamponade with the balloon only.
Yes. So that comment is totally valid in a patient who is pre-tamponade and you haven't got access to the pericardial cavity. If you have got access to the pericardial cavity and the draining is there and hemodynamics are stable, then you can use the same guide, and the blood which is going to the pericardium, if you are draining it adequately, then you can, you can afford it for a couple of minutes or 1 minute or something. But if you have immediately sealed the perforation with a balloon tamponade and the pericardial, spillage or pericardial pigtail has not been placed and the spillage is not that much, and you want to, avoid further deterioration and do not want to put in the pigtail, then totally agree. Keep the balloon tamponade there, get the other guide, along with the wire, along with the PK papyrus, then engage the guide, bring the wire in, and when the wire is there, deflate the balloon, and then, put. Totally agree.
Thank you very much. Very good presentation. Big hand, please, for Dr. Anjum. A few of our panel of experts are absent, so can I please ask Dr. Khurshid to come onto the stage, just so that we can have some more comments. And also Dr. Usman Fahim, to come onto the stage, please. Next presentation. Now, the next presentation, the next nightmare in the cath lab. We have very senior physicians sitting here. Dr. Noori is an extremely senior person. I'm sure, sir, you have seen a lot of nightmares in the cath lab. Any nightmare you would like to share with us until we have the next? No? Okay. Ji.
Was better. The other thing is that we also face these kind of catastrophes in our cath lab, and I looked into the literature but could not find out for how long we should continue a DAPT in a patient in which we placed a covered stent.
As far as your first question is concerned, clopidogrel and ticagrelor, they're equally efficacious as far as their action is concerned. ticagrelor has a leg up because you get plasma availability much quicker than clopidogrel. And as far as ticagrelor is concerned, you don't get hyporesponders. A significant proportion of people would be hyporesponders to clopidogrel. As far as DAPT is concerned, you would probably continue it for the same period of time as you would any other patient. So, now Dr. Anjum from Punjab Institute of Cardiology is going to present his cases.
Okay, so that was a warm-up case, the first one, and this case is more interesting. Okay, what is this 3-dot device? Well, make the guess. Meanwhile, we have to listen to the story and we have to discuss the story until we reach at this slide. This is another 69-year-old male hypertensive who presented with interior wall ST elevation MI and stable hemodynamics. The circ was non-dominant small and there was total mid-occlusion of that vessel. The right coronary artery was dominant and normal. There was a tight distal left main stenosis continuing into the LAD as you can see. So in this case, the PCI left main to LAD was planned for his acute setting. Okay, 2 or 3 complications happened in this case and we'll discuss that. First of all, a BMW wire was placed into the LAD after crossing the lesion. As you can see in the second slide with the arrowhead, the BMW got stuck into one of the septal branches after getting a U-turn sort of bend, and it was not getting out and it was not moving further. When the operator pulled it, you can see the radiopaque part has been elongated. So this was the first complication. So what to do? So definitely we have to remove this wire and place another one. So the operator took another wire. As you can see in this video, DASCO is running. The second wire, both of the wires were twisted together and the second wire was used to bring the first wire out. So again, a new workhorse wire was more carefully placed into the distal LAD successfully and the pre-dilatation was done with 2.5 balloon, including the LAD as well as the distal left main lesion. So here comes the second complication of slow flow. So previously it was a TIMI 2 to 3 flow and now it's TIMI 1 to 2. At this time the patient got symptomatic with worsening of the chest pain, for which intracoronary nitrates, 2-3 boluses were given because and the flow improved. So it was planned to do the immediate stenting. For mid-LAD, a 2.75 millimeter DES was implanted at 14 ATM. Then from left main to LAD, a 3.5 millimeter DES from the ostium of the left main up to the inlet of the first stent was deployed at 14 to 16 ATM, and the left main was gently flared at 18 ATM before removing this stent balloon. So what next? So again, worsening of the same second complication, so we label it a complication 2B. So now, previously it was a slow flow and now it's a no flow. It's a zero flow into the distal LAD, the septal branches. So this time, the patient got more symptomatic and as you can see, the movement of the diaphragm, he also became dyspneic and went into pulmonary edema. The slow flow was treated with intracoronary nitrates, multiple boluses and verapamil, but did not improve. Unluckily, we did not have adenosine at that time. So we again ruptured the same 2.5 balloon, put it into the mid-LAD and delivered the nitrates and the verapamil with less improvement. Then we gave nitroprusside, still no improvement. But then we have to give intracoronary adrenaline and we also gave 5 milligram of bolus of TPA. The ACT was also checked at this time because 10,000 heparin had already been given and the ACT was 380 seconds. For treating pulmonary edema, IV diuresis and BiPAP was also applied in this case. IABP was, the machine and perfusionists came ready, but because the mean arterial pressure along with 3 inotropic support was more than 65, so we did not have to put the IABP. And meanwhile, the flow improved slowly from TIMI 0 to TIMI 1 and then TIMI 2. So after ending of this complication 2B, then we did a couple of views, and what do you know that this cine, and this is present in the last 3 views as well. So from the panel or from the audience, and then we move on, because this was the $1 million question in this case. What unusual finding do you note? There's no dye in that, so that means that has nothing to do with the dye. That has something to do with the hardware.
Is that the wire segment still lying over there that you left behind?
Yeah, and that appears to be any other finding, from starting from the wire and then the stand area, then the guide, and especially around the left main.
Something in the guide as well.
Yeah. So in all the 3 views, when we were treating slow flow, one of the operators also noted one thing, that there's a dot at the guide tip, which you can see over there. Just at the tip of the guide, near the ostium of the left main, you see there's a dot. So what it is and how to get rid of this? What would you do at this point? Yeah, that's great thought. This was my thought as well. So immediately I asked the operator that look at the trolley and look at your balloon. And we also washed up, and when we saw the distal tip of the balloon was missing. That was the perfusion balloon, and I think that was our perforated, and because this no flow remained for 12, 14 to 15 minutes, I think, and they had to use it 2-3 times for delivering the drug, so it was probably not that robust to withstand that. And at the ostium of the left main, where there was struts hanging, it probably got stuck at the guide tip, or some struts over there and it's lying there. So how to get rid of this now?
But this happened after the slow flow.
Sorry?
This happened after the slow flow. The
Yes.
balloon got stuck there after you gave the Aggrastat, which was much later in the complication.
Yes. So how to remove this? What will you do? Sorry, please, sir, get closer to the mic because I cannot hear you.
Catheter in your armory to deliver drugs intracoronary instead of the ruptured balloon.
Yes, we have aspiration catheter. We also have twin pass, and
Would have been safer.
yeah, but complications do happen because sometimes we do not use all the equipment carefully.
Did you use the intracoronary adrenaline after you used the Aggrastat? So what balloon were you using? Was it going on top of this? I mean, you had only one wire in, right? So you had the same wire. This balloon, is it still on the wire, do you think?
Yes, this is still on the wire.
And so when you took you must have taken the balloon back in again to give intracoronary adrenaline after the Aggrastat or some such thing.
Yes.
So this was left perhaps behind at the last time.
Yes, probably.
Probably, yeah.
Well, because it's there in the last 3 scenes. So anyways, so that kept on slipping. Various maneuver was used to, get this out. The first maneuver in the first slide, you can see, unluckily this laser is not, because it's not dark enough, it's not visible. So I would say that in the first, from my side, the first scene, you can see the first, what we tried is, we tried to remove all the equipment, including the guide and the wire, and this dislodged stent balloon as such. But you can see when we are pulling the guide and the wire is going out, the guide is going out, but that dot is still in there. So it's not moving. So that was a nightmare, because now we know that it is sticking with the left main stent or something, so it's not coming back with the routine wire. Okay, second, we wanted to place a parallel wire because we wanted to have a, oh, thank you. That's great. Wanted to place a parallel wire. You can see a parallel wire coming in so that we can have a good safety wire over there, and then we can do something with the other wire and the balloon. So you see, because a couple of 1 or 2 struts were hanging beyond the ostium of the left main, the wire over here, it kept on either getting entangled with this balloon, or when we pull the guide back and try to reorient it, then it kept on going behind the stent struts. So it was not going liminal, it was actually going abnominal. So at this point, we had 2 or 3 options to do with the balloon. Best is to remove this out. The second non-best, or the other acceptable, is we place another stent or something and deploy it, crush it around the left main and bury it. The third option is we get it down into the tip of the LED if we are not able to do anything else. But the best thing was to remove this. And in this slide, because we wanted to put in another wire, but unluckily we could not. So the next thing was snaring or something, because the wire was not going liminal and it was sticking in the ostial struts. So if we take the snare in, that can also get this, stent struts entangled within it. So that was a bad thing. So the next thing, after, frustration we tried to apply was we took a 1O balloon on the same wire. So these 2 balloons were now in line, and we wanted to push it into the apical LED so that we can have a small apical infarct, but we can get rid of this left main balloon in there. So when we are doing this view has stopped, but as you saw that the guide kept on coming out, this was sticking here, the other balloon was not able to push this into the distal LED as well. So what to do next?
Do you have snares in the cath lab?
Yeah, the important thing for the snare would be that we have to either place it parallelly on this wire, or we have to take it as such in the guide. But if you snare it, if this is in this view, you can see that this balloon is, the dot is there. So the tip of the balloon of, I think it's like 3 to 4 millimeter, is still in the left main, and this stuff is sticking in this, struts of the left main over here. And if you are able to capture it with a snare, there is a possibility that you also capture the left main struts as well, left main stent struts, and then you can deform and pull that stent out. So,
yes,
okay, that can be an option. Sorry?
If you try a snare, you're correct that you may snare the left main stent struts also. But that you can put another stent in. If you deform the stent struts, then you can put another stent in to cover that.
Yes, definitely. But we tried some maneuver that we can avoid doing that, because it was a long left main to LED stent, and because the patient already had slow flow. Okay.
Did you try putting another balloon on the side, inflating it, and then,
Yes.
pull the whole assembly out?
Yes. So the next thing which we did was we were able to place another parallel wire. We pulled the guide and hang this parallel wire into the aorta, as you can see over here. Then we took another balloon parallel to that, like you can see, at the ostium of this guide. Then we inflated this. This was again a 2.5 new balloon, and we inflated it at 14 to 16 ATM, and that was able to, this is the dot over here, and we should not forget that there is some amount of shaft over here and some amount of shaft over here as well on this broken balloon. So there was a 3 to 4 millimeter of broken shaft on this side and this side, probably, and that was the place over where this second balloon was able to hug this, capture this, and then, luckily we were able to remove that. And I tell you one thing, up till this time, the time which was taken to improve the slow flow, that was almost 2 times than to do this one. because we kept on changing the strategies. So we did not took a lot of time for doing this one. So this balloon is going out. And the story does not end. There are a couple of slides more, because when we reached at the sheath, this one refused to go into the sheath. So what we wanted that, okay, we do not need it. We remove the sheath and the wire and everything. But luckily, we first pushed the wire BM all the way up to the axillary artery, and then we pulled this assembly, so that if we lose the balloon tip, the wire is still in. And that is what happened.
Dr. Saab has a comment.
Okay.
I want to ask this question from the panel.
Comments.
Because we don't know where is the stuck balloon is. What about the struts of the sun? Because it's in the left main. So it could be very disastrous to use blindly. What about the role of IVUS? If you use IVUS, you will exactly know where is the stuck balloon, how is the struts, and is there any spurs of the calcium which is obstructing this balloon, or maybe the cause for your rupture of the balloon?
Okay, can I answer that? So that's a great question. So the most important questions were a couple of, like, why it happened and where it is sticking, and how much stent struts of the left main they are involved. As we already discussed, that we did not want to disrupt the left main stent. But very, very important one thing, the first step we used in this case was placement of another safety wire into the LED, luminally. But unluckily, after a certain try, we were not able to place a second wire luminally. The wire kept on going abluminal through the stent struts, and we were not sure that it's going luminally, so that's why we were not able to place another wire. And all the current IVUS which are available in Pakistan, they are radial, they are side looking, and there's a need that you cross the point of interest in order to image that area. So in order to get an IVUS in, you need to get a skewer luminal wire into the left main and LED. If your first wire is going, the second wire you place is going through the stent struts of the left main, and then you push the IVUS into the left main or the LED, either it will not go, or you will worsen the condition at the left main ostium. Some part of the lumen is already, occupied this umbrella of balloon, because the dot is there, but this is not the only diameter which it's occupying. There is a umbrella of the, PTFE, polyethylene layer, which is already there, which is also there. So that can cause a slow flow and clot formation in the left main. So IVUS was practically, unluckily, not possible in this case unless we have a forward-looking IVUS.
Thank you. Thank you very much for the wonderful cases Anju presented. And with this, we end the breakfast session for the morning. And now I'll request the panelists to get back to their seats so that we can start the next session. Now we start with the first session of the morning. And in this, we'll be dealing with left main cases and treatment dilemmas with regards to left main cases, isolated circ ostial or LED ostial, and obviously bifurcation stenting. And we have got an elite panel of experts to be with us for this session. So first of all, I'll request the local panelists to come to the stage so that we can start. So may I request Dr. Mohammad Noori, who is the ex-commandant of Armed Forces Institute of Cardiology, to be with us for being the panelist for the session. Then General Retired Azhar Kiani, he is the ex-commandant of AFIC. Also, he is the ex-chief executive of Rawalpindi Institute of Cardiology. Then I'd like to invite Dr. Harun Babar Khan, if he is here. Then Asad Akbar Khan, he is the chief of cardiology at Shifa International, chief of interventional cardiology and structural heart program at Shifa International Hospital. Then Professor Numan Nasir, he is the Chief of Interventional Cardiology at Beria University Hospital, Lahore. Then Dr. Ahmed Fawad, if he is here, then he can join us. Dr. Tariq Shafi, can you join us for the panel, to be among the panel? Now we are joined by two eminent interventionalists from USA. First of all, it's my pleasure to introduce you Dr. Ramesh Dagabuti, who is Interventional Cardiology Chair at West Virginia University. And then Dawn Abbott. She is on the editorial board of SKY, as well as very eminent cardiologist in USA. So these are the international panelists joining us. And first of all, we'll be moving on to a live transmission. It will be done by Dr. Ehtesham Mahmood. And let me introduce Dr. Ehtesham Mahmood is the ex-president of SKY. And he natively belongs from Lahore, and he migrated in late 80s to US. And obviously he has achieved all the heights there. So he is currently the head of cardiology at University College, California. And Dr. Ehtesham Mahmood with his team is there. And we welcome all of them. And let's move over to Dr. Ehtesham Mahmood's lab. Welcome, Ehtesham. I am Professor Zubair Akram. How are you, Ehtesham? So you are live with us, and we have got panelists among us and all the leading cardiologists of the country there with us. So welcome from Lahore. Ehtesham, over to you.
Great, thank you. Can you all hear me? Okay, perfect. Hearing a bit of an echo, but thank you for the invitation. And can we go ahead and play the video, please? Just a quick introduction of San Diego and the University of California, San Diego. That's our Cardiovascular Institute. And as everybody gets a chance to see that, I will also quickly introduce my team here. I have my nurses, Isabel and Sophie, and Tech Derek and Rainier. And to my left is my colleague, Laurent. Our interventional cardiology fellow.
There is some distortion in your sound quality. Maybe you can adjust your mic settings, because we can't hear you clearly.
Our patient is a 74-year-old female.
So Ehtesham, just try again. Maybe we listen to you now.
Can you see the slides?
No, we can't see the slides. We just see you in a box and the ECG, and maybe, just a femoral.
I see. That's what you're getting to see.
Actually, Ehtesham, this is Bashir. Sorry, when we see your slides, it's when both things are on, we are hearing echoing of your voice. So we had to use either the slides or, now we can see the slides.
Yep.
Okay. So our patient is a 74-year-old female with insulin-dependent diabetes, hypertension, chronic kidney disease due to diabetic nephropathy. She was referred to our hospital with new onset ischemic systolic dysfunction and angina on maximal medical therapy. Her medical regimen was amlodipine, isosorbide mononitrate, and metoprolol succinate to maximal doses. She was on insulin and aspirin and rosuvastatin, and we loaded her with Plavix after her. Sorry, go ahead.
So you can move to next slide.
It seems you are mute.
Are you?
Okay, now we can see the next slide. But we can't listen to you now.
Shyam, we can't hear you. It seems you are mute. You have to unmute on the...
Okay, I can.
Yeah, now we can hear you.
I'm hearing us.
Now we can hear you.
Once again, your voice has gone. Yep.
Guys, let's stop that. Okay. Okay. Okay.
Okay, now we can see the echo images.
Okay. You know, I'm not. Keeps replaying. I'm sorry, it keeps replaying the same. It keeps repeating and replaying our recording. Okay. Can you hear me now?
Yep, now we can hear you.
Stop that.
But still not too good. Now we can see your echo images.
Okay, it seems to be the same recording keeps playing. Can somebody just stop all the talk?
The voice quality is not good. We can't hear you clearly.
Why is that happening?
Shyam, maybe you can continue with your case now. We can hear you intermittently. I think you are talking on the phone, or you have a mic with you. Shyam, can you hear us?
Can you guys disconnect and reconnect?
Yeah.
Just try to reconnect, because we can't hear you properly. We can't see the slides.
I'm going to ask to mute all the speakers except yours, all the microphones. Steph, can you mute all the microphones except Dr. Mahmood?
It recorded you guys, and then it kept playing that, whatever it recorded.
Dr.
So we have lost your voice again.
They have restarted their system, so hopefully they'll be back in a minute.
Can anybody hear me?
Yep. Not
Yeah,
very
we
clear,
can
but
hear you. Okay.
now we can hear a bit of.
Okay. You know, it kept playing the same recording. Let me show you where we are in this case. So this is the 74-year-old lady with ischemic cardiomyopathy, ejection fraction 25 to 30%. And we capped her 2 days ago. She had an ostial and distal left main. Also LAD that's occluded, distal circ is occluded. And the right coronary has a proximal lesion with right to left collateral. On the echo, she's got inferior akinesis, hypokinesis of the anterior and lateral wall. So let me just show you what we've done. Can you hear me, everybody?
Yeah.
Yes.
Not too clearly, but still, now at least we can hear a bit of you. So it's a 74 years
Okay, well, I'm going to show you
Yeah.
74-year-old ischemic cardiomyopathy, EF 25%.
Just show us the, angio of the case,
There's nothing shared.
Okay.
There's nothing.
So we went ahead, put an impella. Here's an ostial left main.
So it's not showing computer, but it's not showing home? Nothing. This is amount.
I hear a lot of echo in the background. There's other people talking.
Yeah. Shami, can you hold? Maureen, can you please mute your phone? Maureen?
Yes, it's good. I see. This is number. I'm just into that. All right. You make sure it's not working with good hands.
No, don't see anything.
And it's not showing the computer images.
So ask the striker guy, why is it not showing him?
So, Maureen, you are requested to mute your phone, please. So we have lost your voice, we have lost the, any visual from your center, Ehtisham.
Can you see the images?
No, we can't see.
Ehtisham, can you please start the case and just show us NGOs if possible? Ehtisham, can you hear us?
We have lost audio, we have lost video from your center at Sham.
I think let's start the talk, and then in the meantime they'll try to figure out.
Okay.
So I think I'm sorry for the technical delay. We are going to move on with the talks for now, and then we'll see if we can figure out in the meantime the technical issues. So the first talk is going to be by Dr. George Dengus from Mount Sinai. He's very well known. He's going to be the Sky president-elect as well, and I think one of his, I would say,
I can hear
students,
you. Can you guys
Dr.
hear me?
Asad is sitting here as well. So we're going to go ahead with his talk, and then we'll come back and see if we can figure out what's happening with the Dr. Shyam's case.
Welcome.
Of your meeting, not only as my faculty assignment at Mount Sinai, but also as a president-elect of the Society of Cardiovascular Angiography and Interventions. And I'd like to congratulate you for organizing this great meeting. I'm going to talk to you about left main, of course, but some other aspects, the de-escalation strategy that can be figured out in patients with left main disease PCI. As you already heard in a set of great talks, and we'll hear after me as well in the discussions, left main is a little tricky because there's just so much at stake. And also, more importantly, particularly with the distal left main, the plaques are contiguous with either the LAD or the circumflex. Therefore, whenever we do stenting, etc., then we always have to be mindful of full coverage, of a great result, and again, be cognizant of what our patient may encounter later on and how the medical therapy can be amended or simplified in case other clinical problems arise. So no question that everybody does left main PCI, they have in mind strong antithrombotic therapy, strong antiplatelet therapy early on in order to really have a great acute and subacute result. So everything about antithrombotic therapy now in the longer term and in the follow-up, it's all about evaluating the ongoing bleeding risk and the ongoing, if any, residual thrombotic risk, and see how we can either employ something like very long dual antiplatelet therapy in case we have patients with ongoing problems of thrombotic risks due to perhaps combination of carotid, perivascular, and coronary disease, or many other lesions or special circumstances. And in case this risk-benefit ratio is more towards bleeding, could the dual antiplatelet therapy be simplified in some way in order to benefit our patient? So what's de-escalation about? De-escalation means that after the acute phase, that you really need the dual antiplatelet therapy at high intensity, could this intensity be turned down a little bit, be sort of simplified? There are many ways to do that. One of them is simply to cut one drug. So in many ways, the single antiplatelet therapy is a form of de-escalation. However, there are other ways you can do de-escalation, aside from just stopping the aspirin, let's say, as I said right above. After a few months, you can stop the P2Y12 inhibitor, or you can affect the dosages of any of these medications later on. So you start with a standard dosage early on, and after some time, you turn it down. And of course, one of the criteria you can turn this down, you can turn it down based on a platelet test or based on a genetic test, or you're just going to turn it down on everyone just as an unguided de-escalation, so to speak. But in theory, these are all the possibilities that de-escalation really covers. And what's the rationale? There's a pathophysiologic rationale for it, and it's depicted here. We have local ischemic events, plaque progression and destabilization, and then we have the longer-term prevention of systemic events, as well as the longer-term bleeding problems. Well, the first couple of them, the local and early on events, are sort of front-loaded. So there's a lot of risk over the first month or so, but then the latter two the prevention of ischemic events, particularly multiple territories, and the bleeding events, the really longer term. And essentially, it's a battle that is in depth of time. So what does this mean? Briefly means that early on, we really have a lot of thrombotic risks. Later on, we continue to have bleeding risks that don't go down. So naturally, one can just look at this graph and say, you know what? Why don't we dial up or escalate the antiplatelet therapy early on, and then we dial it down later on, or de-escalate it if patient's doing well, and I'm very concerned about the longer-term bleeding risk. That is, in simplified way, that's why we're considering this. What are the different options? As I said, on the left side, you can see the standard antiplatelet therapy. We have the aspirin de-escalation with a planned stop of aspirin after a month or so, or a planned de-escalation of the two P2Y12 inhibitors by just stopping them after a few months, or switching to a lower potency P2Y12 inhibitor, like either ticagrelor or prasugrel becomes clopidogrel, or you decrease the dose. So the prasugrel or the ticagrelor are continuing, but at a lower dose, maybe half the dose. The ticagrelor can become 60 twice a day, or the prasugrel can become 5 instead of 10 milligrams daily. And of course, you can do also a testing, as I said, the platelet testing and a genotype testing, essentially to verify that the patient is well responder to clopidogrel, and then avoid the more potent agents in specifically those patients. So this is a schematic of all the possibilities around the de-escalation. How to de-escalate, and particularly also sometimes how to escalate or how to initiate an alternative antiplatelet agent. It's a little complex to go through all the possibilities, but you can see the 2017 paper that includes all the possibilities. Essentially, the more important is when you're initiating clopidogrel, after discontinuing the ticagrelor, you have to load with clopidogrel, 300 or preferably 600 milligrams. Where the prasugrel and the clopidogrel have a similar mode of action, the pharmacodynamics, of course, more potent than the prasugrel. The ticagrelor has very different, and it's a concentration base that's going to rapidly decline. So you really need to load the platelets with clopidogrel when you're de-escalating in that direction. Regarding the platelet function and genetic testing, I think one can say, of course, both of them are somewhat expensive. Perhaps the genetic testing more expensive in different areas of the world, and someone needs to evaluate those possibilities. The easy thing is that the genotype testing, you can just order it as a blood test, and then the result comes later. The platelet function test, the result, you get it immediately, so you can act upon immediately. On the other hand, you have to have a setup machine, etc., in your own laboratory in order to be able to do it, or the cath lab, as I should say, in order to be able to do it. There are several meta-analyses. I'm just going to give you a glimpse of the latest meta-analysis that we performed that indicates a clinically, I would say, interesting aspect, because not only do we analyze many studies, a large number of studies about bleeding as about major adverse cardiac events, and we found a consistent decrease in bleeding with no effect, or even better, major adverse cardiac events with de-escalation. We also found that the unguided, the simple de-escalation, so to speak, seemed to work out better. Why is that? Perhaps because it was simpler to do, and perhaps errors or mishaps were happening when you try to interpret genetic or platelet testing, and for whatever reason, they weren't really happening. So this is what we found, and you can see the European Heart Journal paper a couple of years ago that solidifies that unguided, simple de-escalation is actually easier applicable, gives lower bleeding, as well as great results about MACE, no concerns at all. Specifically with left main disease patients, there's one study that had a lot of left main disease patients, and this is the Korean study, Host-Reduced Polytech. And you can see here the summary, as well as a relevant paper regarding the complex PCI that did the escalation, had again tremendously good results. You can see the bleeding events, regardless of the PCI complexity, were much more dropped down. You can see at the bottom of the slide, the complex PCI had a de-escalation risk of MACE of 0.88 and a non-complex PCI 0.81. So no concern at all for the left mains and other complex PCI cases about de-escalation. In this particular study, the de-escalation was done by reducing the dose of prasugrel for 10 milligrams to 5 milligrams a little later after the PCI. And they consider the results in 1 month. So essentially, there was some difference of about 11 months in the de-escalated versus the routine dual antiplatelet therapy. The bleeding was reduced regardless. So in some ways, the simplified unguided de-escalation with a potent PD-L1 upfront and a reduced dose later on might work and serve very well the community of the complex PCI patients, including some left main cases in this particular study. I think very, very reassuring and very, very pertinent to your conference. In conclusion, de-escalation, first of all, commonly occurs and occurred all the time in clinical practice, even before it was studied. Why? Because initially it was quite frankly driven by cost, a cost reduction, a cost containment. Routine de-escalation for anyone should not be recommended at this time, but could be considered. I don't think that I'm de-escalating everyone up front at the time of PCI. The de-escalation is a decision that you take at the 1 month or at the 3 month or at the 6 month follow-up visit after the initial PCI if everything goes well and there's no problems. And the benefit is to reduce the morbidity from follow-up bleeding. Interestingly, there were no concerns about increasing MACE in any way, and the modes of de-escalation was to either convert a potent inhibitor to clopidogrel or reduce the dose of a potent inhibitor, or simply reducing stopping one of the two drugs anyhow. There were considerations about the platelet functional genetic testing, but looks like the de-escalation, unguided de-escalation should be simpler and more beneficial. When you're switching the drugs, you need to really be sure if you need to load or take special measures, and that's why I offered the guide in one of my slides for this particular aspect of this clinical practice. I'd like to thank you so much for your attention and remind each and every one of you is a candidate for international membership in our Society of Cardiac Angiography and Interventions. Then you can see the 2 upcoming conferences. One is just next month in Phoenix, Arizona. But most importantly, you can plan from now for next year, May 1, near Los Angeles at Long Beach, California. So long, and thank you so much for your attention.
Thank you very much, Dr. Dangas. We are going to go ahead and move on to try to see if we can see the case from Dr. Ehticham again. And we'll talk about question answers later on. Dr. Ehticham, you're online. We can see your images now. You're working. So can you hear us? Dr. Ehticham, can you hear us?
Ehticham, can you hear us? So it's as far as we saw, it's a 74 years lady with chronic kidney disease and obviously ischemic cardiomyopathy, low ejection fraction, and then we can see this ostial left main followed by ostial LAD maybe, and Impella being there and now is wiring this, it's a femoral approach, so that's all we can see right now.
Dr. Ehticham, can you hear us?
I can hear you. Can you hear me?
Can you hear us, Ehticham?
Ehtisham, your audio is off. We can't listen to you.
Can you hear me now?
Yes, we can hear you now.
Okay.
Not very clear.
All right. Let me just show you where we are. So, as you all recall, 74-year-old ischemic cardiomyopathy, EF 25 to 30.
Now it's better.
CKD with a creatinine of 2.
Yeah.
We went ahead and got a single femoral access, placed an Impella CP. There's an ostial left main. There's long LAD, prox circumflex into the obtuse marginal. The LAD's mid-vessel occluded. And we also have a prox right coronary lesion. This is a 7 French 3.5 guide catheter. We're using bivalirudin for anticoagulation. We use a Xi'an black to cross the LAD over a microcatheter. Switched out to a wiggle. We pre-dilated that with a 2015 emerge. Up and down the LAD. We went ahead and put a run-through wire in the circumflex OM and dilated that with a 2.0 balloon. Then we went ahead and did intravascular ultrasound of both the LAD and the circumflex. I wanted to show you here. Hopefully everybody can see.
Now we can hear you quite well. Ehtisham, what's the status of right coronary artery in this patient?
Good. Can you see the images as well?
Yeah, now we can hear you nicely and we can see the images also.
Oh, perfect. So the right coronary artery has a proximal 75% stenosis with right to left circumflex collaterals, but the distal left circumflex territory we feel is infarcted. On the echo, the inferior wall was akinetic. And the anterior and lateral wall were severely hypokinetic. So we've dilated the LAD and circumflex. And here what I wanted to show you is when we did intravascular ultrasound, it's a diffusely diseased vessel, but that particular spot is angiographically calcified and on IVUS at a 360-degree calcification.
So is it a superficial?
IVUS of the Go ahead.
Is it a superficial calcium?
It's actually pretty deep. I was going to use shockwave, but then time was of the essence, so I went ahead and put a 2.5 NC balloon at 22 atmospheres, and it finally yielded. So the much more cost-effective strategy after I've spent all the money on the Impella. And we went ahead, this is, I think, when you went to the talk, so we put a 2.5 38 Xiant stent. And this is followed by a 3.5 18 Xiant stent. Then we went ahead and went caudal, and we just put in a 2.25 18 Xiants, and that's where we're at right now. So our plan now is we've gotten our LAD CTO opened up. We have the mid LAD stented to back to the prox. We've got the circumflex stented distally. Here's what it looks like angiographically at this point. And I would love to hear from the panelists and everybody else what approaches we can take.
Yep. The mid LED stent looks a bit underdeployed. We have got panelists here with us. You know, it's Dr. Asad Khan, General Kiani, Numan Nasir, and Tariq Shafi. So, panelists, over to you. Do you have any questions?
Well, if you don't mind, we can ask the panelists online. Maybe Dr. Abbott, if you would like to give any
Dr.
comments.
John Abbott?
Yes. We need to cover the ostial left main as part of the approach. It appears that the ostial circ is relatively free of disease, but Shami, I don't know if you can comment on the Medina classification here, whether it is, you know, how involved the bifurcation versus, it seems to me you're going to have a strategy of LAD stent back to the ostial left main. And then the way you treat the circumflex will depend on the involvement there at the ostium.
Agreed, Don. So we felt it was a 0-1-1. The ostial circumflex, the angios you're seeing now are post-predilatation. So our plan up front was that we needed to stent both the LAD and the circumflex ostia all the way back to the left main. And then, of course, there's the ostial left main. The mid-body of the left main is actually not that diseased, but I don't think I want to leave any segment alone. So we're going to quickly post-dilate the LAD. Let me show you what that looks like, and then we'll decide on how to stent this bifurcation. So not sure, maybe we'll wait on that. Let's go ahead and do the bifurcation while everybody's here. So
what's
let
the
me
viability?
first go ahead with the, what we'll do is take a 4015 NC emerge and a 3523 Zions.
Shyam, we have.
So my plan is to stent the circumflex ostium all the way back with a 3523. We'll crush it with a 40 NC emerge in the left main and LAD. And then we'll go ahead and stent the left main.
Shyam, we have Dr. Chen here with us on panelists. We would like him to say a few things before we move on.
Yeah, good morning.
Xiaoling, it's great to hear your voice.
Yeah.
Tell me, what do you think?
Xiaomi, can you hear me?
I can hear you, yes.
Congratulations to your great case. Angiographically, according to the definition criteria, so this left man could be classified by a simple bifurcation because they very mild stenosis as the circumflex. So personally, I prefer to use a one stent technique from LAD to fully cover the ostial left main. Thank you.
So, sorry, Xiaoling, I just heard you at the very end about the one stent covering the ostium of the left main. What was your earlier part of the question?
Yeah, I don't think so because left main is pretty short than 10 millimeter, I think. So I prefer to use one stent. So what's your strategy?
Yes, so my plan is in the left main, I agree. So I've stented the LAD all the way back to that, from the mid to almost prox LAD. So my plan now is to go ahead and first have a balloon in the left main, and we'll stent the circumflex. Then we'll put a single stent that covers from the ostium of the left main all the way into the LAD.
Okay. So this is the balloon.
What do you think of that?
This is the balloon in the circumflex, right? It's a gel balloon.
This is now a stent. So this is a 3523 stent in the circumflex, and I'm going to take a 4015 or 20 NC emerge. What do you guys have?
I'm sorry.
420, we'll take it. So we'll put the 40 balloon from the left main into the LAD. And Xiaoling, maybe you can comment on this because I generally am pretty aggressive on using a large balloon to crush the side branch stent as opposed to being conservative on that size.
You are the master of DK crush.
Ramesh, Ramesh, do you have any comments? Dr. Raghavati, are you there?
Dr. Ramesh, can you hear us?
So any other comments from any other panelists? Dr. Tariq Shafi, how would you do anything different?
So here we go.
In
We're going to the left. Yep, let's go to
it's eccentrically and at the same. We like to do.
So hopefully all of you can see this. We've just got our circumflex stent. Obviously, we want to overlap it, and let's get the guide in.
Now, Shami, you've already imaged, so you know the sizes of all the stents. So for the balloon for crushing in the left main, I would use 1-to-1 size to the left main to assure adequate crushing of the stent. And it looks like you're back about 3 millimeters, maybe just a few millimeters or even a nano DK crush.
Yeah, usually the protrusion of side stent is around 1 to 2 millimeters. That's enough.
Yeah,
So
well, I'm feeling pretty good about that right there. It's overlapped and it's back to where I want it. So this is the circumflex stent, not quite yielding, Floral. Oh, it was a little tricky there.
Looks like calcification.
We IVISed. It was calcified, but I didn't think it was that calcified. So I'm now at 16 atmospheres.
You pre-dilated it as 2.5 NC? This circling?
I did. Yep. 2.5 NC. So.
Yeah, you could probably pull it back and go up to higher pressures.
That's the plan. See, I knew Ramesh. I recognized that voice back about a second.
Yeah.
So
Yeah, I
that's
think-
the next.
Yeah, you can also
not
switch
that
out to
one.
an NC balloon, before you go ahead and do the crush.
Agreed. So let me try this. If this doesn't work, then that's exactly what I'll do. And a little bit on this one.
I see
You
a
have
good.
the OPN, Shami?
I don't have it.
Yeah, do you guys have the OPN in
Sham?
Pakistan?
Yep.
Sham, is OPN available in US?
Yeah, we just got it now, OPN, and it's just been approved about, I think, if I'm not mistaken, 2022 September, October.
Let's take that. We'll take a 3.512 NC, please.
Yeah, I think
All right, so we're gonna-
it adds to the options for acute stent under expansion. Certainly we don't want ablative therapies. Often if we end up in this situation and high pressure NC doesn't work, obviously OPN's a newly available in the United States. I think learning how to use it without risk is what we're trying to figure out, sizing it a little bit small and, making sure it's not oversized.
Well, I'm going to try the 3.512. If it doesn't work, I'm going to shockwave this.
Yeah.
Yeah.
I think. Yeah, and shockwave is an option. It might affect the drug to some degree, but certainly better than leaving it under expanded. And other option would be laser.
At the
So
Sham,
in the acute setting, like right now, is that does everybody agree with this approach? 3.512 NC. If it doesn't yield, we'll take a 3.5 shockwave.
Yeah, I think in the absence of having the OPN shockwave, yeah.
All right. So my team, get ready. IVL 3.512.
What size balloon did you pre-deal with?
2.5 NC.
Yeah, I think that's the issue, probably just too undersized.
Yeah. So for the IVL, I try to see what is the EEL to EEL on the IVUS and size it by that, especially when you have an underexpanded stent. Do not size it based on the lumen.
Well, here we go with a 3.512. I'm starting to feel pretty good.
So John, as we discussed this very early morning, so now Shami is doing optimized side branch stent. I think this is very important for optimizing side branch
That's
stent.
at 22 atmospheres. I'm feeling pretty good. We don't need IVL in there.
So it's 3.512 NC at 22.
I'm sorry?
It's 3.512.
That was
at
3.512 at 22.
Sham, what's your strategy to reduce the risk of this further kidney injury? How much dye have you consumed and any pre-procedure preparations for that?
Yeah, good question. So when we measured EDP, it was 24 today, and that's a good question. And maybe Don, you can comment, and others can comment. One of the questions that we're trying to answer out of the Protect 4 study is there value in the use of hemodynamic support, specifically Impella, to preserve renal function. So obviously we're trying to limit the amount of contrast we use, but the other element of it is that very question to answer. Hemodynamic support, specifically with Impella, doesn't actually protect the kidney. As far as contrast is concerned, I am trying to limit it. It's one of the reasons I didn't do the right coronary today. So we are now going to go ahead and so again, another question I'd love to ask the group. Let's put the balloon in first. So we're going to put a 4-0 balloon first across, and then I usually pull my side branch wire out at this point, as opposed to leaving it in. I've heard some people tend to leave it in. What do most people do?
So you always take this side branch wire out, but we have seen so many of
I
experts.
always do.
But we have seen so many of experts keep this wire in. So what's the incidence of this wire trapment with the other experts?
So that's what I want to hear.
Yeah, I think it's quite small. I mean, certainly in a non-stented vessel, I would always leave it in and leave it in for the proximal optimization. In the stented vessel, with just the first half here where you're doing the crush, I think it's perfectly safe and unlikely to become entrapped because you're really only deforming a little bit of the metal onto that wire. And but after the first kiss and going for the stent across, then I would certainly remove it at that time because then it's metal on metal. But if it's balloon on metal, you're usually fine, no issues. But watch the guide, particularly with left main, when you're going to remove any trapped wire that the guide doesn't.
We'll take that run through wire.
The left main stent.
Thank you.
So Don, believe it or not, after almost 20 years, I recently entrapped the side branch wire through it was a calcified vessel, sharp angle. And that was a pretty harrowing experience where it unraveled, took us forever to get it out. We were able to get it out. So that's probably what changed my practice.
Yeah, I think the calcification, angulation, amount of trapping, again, for the left main crush, the amount of proximal stent is very, very little. So when you're doing a normal, for the crush part, for that first, the step you're on now, but later on, certainly I would remove it.
Yep. Right. So our step here is we're going to go ahead. So we've crushed our side branch, sides, and I want to make sure, there we go.
Now, rewiring this side branch in the left main in terms of the struts that you would be looking to rewire through distally, proximally. Can you elaborate on that?
Yeah,
Dr. Chen?
I love that debate. Quite frankly, as long as I get the wire down, I've never adjusted it. That'll be my honest answer.
Yeah, I think anything but extremely distal is fine.
Right. So I'll take a fresh 3515 NC, please.
Personally, usually I prefer to use non-hydrophilic wire to recross the side branch. So for this
3.0 and
case,
3.5?
for this case,
All right,
Xiaomi,
3.5 and 3.0.
So for this case, Xiaomi, I believe you rewire from the proximal cell into the thin flat. Amazing technique.
Would you like to crush with a larger
So I
balloon?
think what we'll do,
Pot balloon?
Xiaoling, next is we're going to obviously put an NC balloon in the side branch and the circumflex, and we'll put another NC in the left main LAD. And
So from my
once we do that first kiss, then we're going to go ahead and put our stent.
Yes.
He did use a 4.
Okay.
So the traditional teaching is proximal cell for DK crush and for distal cell cross for proximal cell provisional stent strategy. But that's it, as Don mentioned, or even
To
as we've
confirm the
seen,
crush,
take whatever you
you
get
use
there.
imaging
Do
IVUS
not spend
before
too
you
much
deploy the
time.
main vessel stent?
But if you're really interested, you can probably show a stent boost to see where we are. And I think, but I agree with Shaoling, it looked like a proximal cell cross here in this particular case. And I think jailing the wire for people who are in the audience and trying to learn DK crush, it's better to follow, again, the traditional teaching is take the wire out as you have seen in the live case and don't jail it. And until you do become comfortable and maybe as an expert's hands, you can probably jail the wire, you know.
I mean, what is
And
the
I think
benefit
the
of
one
jailing
comment
it
I
in the
would
crush
make is
stent?
do
There
not
is
ever jail the BMW.
really
I
no
know a lot of
benefit.
people
You
no longer
just,
use the BMW, but that's one wire I don't like to jail.
Yeah.
So is there any benefit of keeping the wire there?
no, not really. I mean,
I think theoretically the idea is, it's a wire out of it, that if you were to, you're more likely to supposedly have a patent vessel. You can see this NC balloon crossed really well, and so we're in a good spot.
You're right. So,
What are the sizes of balloon to the side branch and the main, left main?
Yeah, so 3.0 and 3.5. 3.0 side branch, 3.5 in the main vessel. In a little more.
Very easy to cross.
And what's the pressure?
Very easy to cross. So, which one?
The general guideline is size it 1-to-1 to the distal main vessel for the main vessel balloon and to the side distal into the side branch. NC balloons.
You have got 3.5 in the left main, I think.
So, yeah, there we go. Let's come back a little bit. 3.0 in the circumflex, 3.5 in the LAD. Go ahead. Everything will both go.
The C balloon, is it? 3.5 and.
Well,
how are the impeller flows right now, Shami?
Oh, good, yeah. So Impella, it's, for a lady like this with an EF of 25, 28%, has, I think, really made this whole procedure go very, very smoothly. We've had no compromise. We're in auto. We have 3.8 liters a minute. And maybe Ramesh or Don, somebody can talk about Protect 4, because I was going to randomize this lady into Protect 4, but I wasn't sure which way it would go today, so I decided not to randomize her. But she would be a perfect Protect 4 candidate.
Sure, yeah. Protect 4 is looking at ACS presentation, non-STEMI or STEMI with multivessel disease or ongoing angina as well. And those patients
so what do you guys want to stent this for now?
are being enrolled in Impella versus standard of care, which might include a balloon pump or nothing at all, and doing a
28 or 23
or non-left main multivessel PCI. This study is probably to help us get
these 20s
to the guidelines.
Yeah, and I think the important part of the trial is
Or
that
28
if you're
science.
in the non-Impella arm and the patient decompensates, you cannot then use Impella. So most sites would have backup ECMO or another circulatory support device that's, a step up from a balloon pump.
So I don't know where we are with time, but so we've got this 3.5, 23 in the circ. That was high pressure non-compliant. We crushed it with a 4.0. There's our first kiss. We're about to put our stent in the LAD and left main. We're going to do that, then we'll pot, and then we'll recross and do our final kiss. Followed by a final pot.
And then I was.
So, Bacha,
Absolutely. So we IVUS at the very beginning and we'll IVUS at the very end. My fellows have convinced me to IVUS at the beginning because Abdullah to my right, he's a second-year interventional fellow. He's almost finished. IVUS for him is now like, I don't know, it's his soother. Without it, he can't do PCI. So he's convinced me that I better start getting up to speed. Are you all using IVUS in most of your cases? Non-left main?
Every single left main and bifurcation complex PCI, CTO. I mean, rarely. Maybe skip an acute MI once in a while, but at least 80%.
So, Bashir, usually I will keep wire in the side branch before ballooning quash. But after first teaching, I will remove the side branch wire. Thank you.
Yeah, Shaolin, I'm with you on that.
Yep, I agree.
Xiaoling, I missed that comment. Sorry, what did you say?
You're going to remove the side branch wire, right, Shami?
Yes.
Yes, that's what you're saying.
First, let me just get this all positioned up. I think we're in a good spot. Yeah. So another point, I always, and Bilal just pointed it out, we like to place the ostium of this in the left main in the LAO cranium.
3.5 stent? The stent you are putting it now from left main
Which
to
stent
E
LED.
you are putting in at the Shah? Which stent you are putting in?
Is it 3.5?
It's a 28 Zions that we're going to obviously dilate bigger.
So what about your choice of ultra-thin strut stents for left main? Do you use them or just go with the extra strength stents for the left main?
Yeah, I pretty much use this or the Megatron. Once in a blue moon, I'll do a Resolute. I can't, no. Sorry, I'm just trying to line up, trying to determine exactly where we are from an osteo standpoint.
I mean, most of the time, the left main is going to be above 3.0, so even the ultra thin are probably similar to the regular thin struts. I think as long as you have the correct expansion profile, that you know you can reach the diameter of the left main, then probably any of the contemporary stents that we have at least available would be acceptable. You may have additional stents that we don't have available.
It's been tricky to exactly figure out the ostium in this particular case. I've had to do multiple views.
Yeah, I was going to say you have two possibilities to IVUS from the LED stent to the left main. If you have IVUS on a pullback to get an exact length, that would give you a really excellent, measurement. And the second thing is to IVUS mark against a bony landmark or another, something you can use that's non-angiographic if you're having trouble.
Yeah, well, you guys hopefully can all see the trouble that we're having. So I'm going to go back to my diagnostic because I was pretty sure I knew where it was.
In terms of
You can leave the wire also in the sinus and probably use Osteal Pro. I don't know whether you have them available in Pakistan or...
Osteal Flash?
Yeah, Osteal Flash, yeah.
Yeah, they were back ordered. We finally got some today.
We don't have them at all because of the back order. So.
Yeah. Panel, do you have Osteal Flash available in Pakistan?
Which anticoagulant is being used? Can I ask this?
Oh, which anticoagulant?
Oh, we're using Bival.
We generally use heparin, unfractionated heparin for complex PCI and pre-treat everybody with a potent P2Y12.
The part I get annoyed by, I'm going to deploy here. Everybody happy? About the
you're happy.
heparin. Yeah, I think so. But the heparin part is just all these ACTs to check.
Yeah, I think if you're
down.
in a complex case, having the nurse have the ability or the tech to check it every 30 minutes from another line is very helpful.
Well, Impella was great for this portion, I can tell you. Yeah. So we're just going to go up here, we will pot, and then we will...
What is the ACT you are maintaining?
You know, so with bivalirudin, once it gets over 300, we don't check it again. So what was the ACT in this case? I think we checked it early on, and we haven't checked it again. 286 is what it was.
Yeah, that's one advantage of using Angiomax. Like once it's you've achieved it, you don't really need to check it. We use heparin most of the time, so in Pakistan we have to.
So we're going to pot with a 5-0, and then we'll recross for our KISS.
Would you like to loop a second wire in the aorta for precise placement of stent at the ostium and avoiding stent crush with the second wire looped in aorta?
I think Dr. Tariq Shafi has a question. Just to avoid this guider getting into the ostium of the left main, he is asking you if you can place a second wire and make a loop.
We could absolutely, you know, now we've already stented it, but yes, that's obviously a great strategy to just put a wire in the sinus there. So right now, we're going to quickly pot, recross, and finish with a KISS.
Yeah, because your left main is stented, so we should be very cautious about the longitudinal compromise by guiding catheter.
So was this patient preloaded with ticagrelor or something else?
I'm sorry?
Was this patient...
Were they pre-treated, Shami, with Brilinta or any P2Y12?
She was pre-treated with clopidogrel.
Oh, are you guys doing testing?
Yeah, good question. So, you know, we did a lot of those studies early on. At this point, we are not. And in fact, my plan was to switch her to TICAG.
Yeah, I was
She came in as an ACS. She's got left main.
Yeah.
And pretty extensive stenting. So, yes. Yeah.
So this is a full balloon.
So this is a 5015 NC. We're going to pot with that and...
Sorry, Sham. So what's your usual depth of choice for left main? Like, do you use ticagrelor or Plavix, or is Plavix because of possibly avoiding groin complications in this particular case?
Yeah, I wouldn't say TICAG would affect my groin complications. I think we should have preloaded her with ticagrelor. That's what we should have done. But she was loaded with Plavix by the house staff, and so we just kept it going. And in fact, Abdullah here, our interventional fellow, brought up that maybe afterwards we switch to TICAG, which I think we will. We'll take a run through, please.
There is a question from the audience on interactive panel. How common you see dyspnea with Brilinta, ticagrelor, in your clinical practice? Dr. Abbott or Dr. Rakabati?
Very rare.
I've seen it less than was reported in the Plato trial, which was upward of 10%. I think it's pretty rare.
I agree with Don. Yeah, very rare.
Okay, guys, so as you can see, we potted the left main with a 5-0. We will now cross into the circumflex, and then we're going to go ahead and do our, there we go, second KISS. Following that, we'll do a final pot. And I think I'm probably going to need to optimize some of these distal stents with some post-dilatation, which we'll do.
Which wire is being used for recrossing?
Which wire is
this is a run-through. You can just take it down if you want. Yeah, it's fine. Good. Yeah, press 3 up. 3-5, we'll take that for the...
So for recrossing, does it really matter where you cross?
I think Bashir, we were just talking about that. We try and go into the proximal strut, but as I stated, my own goal is just to make sure I can get something across.
So now
So,
which balloon size you are using to cross once again?
we have a 3.5 going into the circumflex. And probably a 3.5 in the LAD. I'll take the. Perfect. So that's a 3.5. You saw how easily it crossed into the side branch there.
Xavier, nice job with the sizing in the left main.
I was just going to compliment Xiaoling Chen because I think he's made our job so much easier. I remember in the past when I used to spend a long time trying to wire the side branch and then try and find something that would cross it.
Thank you,
I think if you follow the technique well, it works quite predictably.
So did you go with an NC balloon in your circ?
Yep. It's a 3.5 NC in the circumflex. We're going to put a 3.5 NC in the LAD. We'll alternate high pressure and then finish with a KISS. Okay, great.
Both 3.5.
Back to the issues with the acute kidney injury. In the absence of other factors other than the contrast that can cause nephropathy, most people are using a cutoff of the contrast volume of 3 times the GFR. If you keep that below that threshold, you can reduce your risk.
Ready?
And for individuals not in heart failure, using aggressive hydration, you could use from the trial data, you can use up to 5 cc's per kilo hydration per hour if the LVEDP is normal at the beginning of the case, under 12. And usually between 12 and 18, 3 cc's per kilo per hour, and above 18, 1 cc per kilo per hour. So aggressive hydration if tolerated and low contrast. But I think what Shami's talking about is that acute kidney injury can be contrast-induced and non-contrast-induced during PCI. So if you have hypotension, then that would contribute. And whether hemodynamic support devices can, in fact, reduce the risk is unclear. So that'll be something of interest.
So Shami,
yeah, and that's one of the sub-studies out of PROTECT 4. And so we will answer that question. We're actually doing very detailed measures. Post-PCI, they'll get daily creatinines for 5 days. And patients take a machine home and measure it every day. So it's probably the first study where we're going to systematically look at that. He came back.
So, Sham, if you could move a little bit faster, we have like 5 minutes more. We can extend to 10 max.
Perfect. You know what I'm going to do? Perfect. So, Bashir, what I'll do is we'll do this final pot.
Yeah.
And once we've done the final pot, we'll take some pictures, and then we're still going to IVUS, but because I can't transmit the IVUS, I'll let everybody go at that point. Maybe in a little more. Go back a little bit below. There you go.
This is 512 NC?
This is a 5.0, yes. So we're going up with a 5.015 NC. Our final pot, we're going to hit it one more time at the ostium, and then we'll take a picture. Guys, go ahead and get the IVUS ready. Oh, too far back. Got it.
Did you pre-close the femoral access?
We always pre-close the femoral access, yes, if we can.
It's a single axis.
Oh, yeah, yeah, yeah. All right, so let's show you the final picture. Like I said, we still have IVUS to do, and we probably still have some post-dilatation in the distal stents to do. Let's just get a coax here. Good, nice. Yeah, actually, let me just...
You plan to do IVUS also?
We are going to do IVUS, yes. Ready? But I'll show you the pictures here. See?
Looks very nice.
That looks quite nice.
Looks quite nice.
Can we have a AP cranial view?
Yep, that's our next plan. So that's AP caudal, or with a slight LAO. The LAD. Abdullah, you pull the wire back. Okay, that's all right. There we go. That's good. That's good. Perfect. So here's our final AP cranial.
Maybe you need some post-dilatation in the mid-LAD stent as you have already planning, you know. Otherwise, the
Correct.
results
I think I'll do.
Otherwise,
Exactly.
the
The
results are
mid-LAD stent, and I think I'm happy with the left main and the proximal, but we'll hit up the rest of the LAD and then we'll IVUS.
Yeah, it's a wonderful result, you know, and the patient is well controlled on this Impella, you know, maintaining the blood pressures and everything, you know. And obviously, this kidney function needs to be followed, as you say. So it was a wonderful, you know, session with you for the initial hiccups, except for that. Otherwise, all the case very went well after that, you know. And any comments from the panelist, Dr. Chen? Any final comments?
Yeah, so far I have no more comments, but after I was, probably we need to do more post-dilation for proximal AD.
Dr. Ehtesham, my final question to you would be, you know, in this case you opted for a DK crush. What are your preferred strategies to Dr. Abbott as well and Dr. Ramesh also? Whether, you know, Europeans, they are more fond of this Q-lot. What about any role of mini crush in the left main stenting, and or just you go straight away with DK crush as your preferred choice?
So I'll just quickly answer and then others can. My preferred choice is DK crush, but if the side branch is relatively, you know, limited in its disease, like a focal disease, I'm not averse to mini crush or Coulot. It depends on the anatomy, but I would say for the vast majority of cases, DK crush is our preferred approach, and provisional we only use if the side branch is spared of disease.
Dr. Abbott and Dr. Ramesh?
Yeah, I think for true complex bifurcation disease, according to definition criteria or similar other simplified criteria, I would go for DK crush, but if the angle is more right angle, could be very small, like nano crush, more like a T. I don't favor the culotte as much. If I'm going to use a culotte, I would certainly do a DK culotte and make sure by imaging I've done a good job, but I have no trouble doing a provisional if there's simple bifurcation in the left main, if it's optimized.
You know, because this DK crush, you know, you go with multiple balloon inflations, more dye. So that was actually one of the reasons I asked you questions in this case as well. Dr. Ramesh, any comments, final comments from you?
I think he had to run and get a call.
Okay,
but,
thank you.
I do think most of the steps of the DK crush can be done with no contrast.
There is a question from the audience. Dr. Anjum Rana is an interventional cardiologist here. He wants to ask a question to Dr. Ehtesham.
Thank you. Sir Ehtesham, because this contrast and issue is under discussion in bifurcation, if you want to go for a zero contrast in some case, so which strategy of bifurcation you will select in your patient? if you want to go with absolutely zero or near zero contrast, or like doing only one final shot?
Yeah, that's a really good question. I would say that if I was truly going for zero contrast, I would, with a final approach only, that's where I might prefer a provisional approach. But if I do have to do the side branch and provisional, the truth of the matter is, you don't need a lot of contrast for DK Crush. Once you start laying down the stents, you don't necessarily need to do a lot of angiographic images.
So thank you.
So,
Yeah,
Sorry, I just want to ask.
you don't really need to take pictures in between the initial placement of the stent and the final kiss. You know, especially if you've IVUSed and you know the length of your main vessel stent and the length of your side branch stent, you don't really need much dye.
Okay, there are some case
Actually,
reports
for
on-
the interest of the audience, tomorrow, we'll be having case presentations with zero contrast. Yes, Jalal Kiani is there. He has a question.
Question to Dr. Ed Sham. This is Dr. Zakari. Ed Sham, what are you going to do about the distal LED?
Distal LED, yeah, good question. So as you can see, we're now optimizing our stent in the mid LED. The distal, this whole thing was occluded. And so I think that what I'm going to do is not chase myself any further and see how it remodels. And hopefully some of it will remodel in our favor. But good question. I don't think I want to stent any further down.
So was there a heart team discussion before you picked up this case?
Yes, so I did the diagnostic 3 days ago. We had the surgeons. We actually did 3 cases that day, all of which I wanted to do PCI. All were multi-vessel. They took the 2 easy ones, and this is the one we're left with in the cath lab.
So I think that's it. And we are really thankful to you, Dr. Sham. You are a wonderful operator, and we are so thankful for you and your team there at San Diego for being with us. And you were the first one getting live this morning. It was a wonderful experience. Thank you very much, Dr. Sham, all the team from San Diego.
Great. Well, thank you for having us. We really appreciate the invitation, and I'm sorry I couldn't be there, but next year I will.
Thank you so much. It was an excellent case and excellent demonstration of the DK Crush technique. I think just a few glitches in the beginning, but later on everything went very well, and I'm really grateful for that. Dr. Abbott, I know it's too late after midnight for you, and I'm really grateful that you were able to be here despite being there that late. So if you have to leave, that's fine. You can leave. Thank you very, very much for being there with us.
Thank you, Dr. Abbott. So now, we are back for the talks. And for the next talk, I'll request Dr. Asad Khan to introduce the speaker, because he has worked with him. And this is Dr. Annapurna Kini. And over to Dr. Asad Khan to introduce the speaker from US. Dr. Asad.
Yes, it gives me great pleasure and honor to introduce Dr. Annapurna Kini. She's the Professor of Cardiology at Mount Sinai. She's Director of Cardiac Interventional Cardiology Program, the Structural Heart Program for the entire Sinai Health System. And in addition to all that, she is the highest volume female operator in the US. She has the best safety record for the last 12 years in New York for complex coronary interventions, and probably very well published as well. So all to you, Dr. Zubair.
So over to Mount Sinai, and it's Dr. Annapurna Kini to deliver the talk. The topic of the talk is Best Strategy for Left Main Bifurcation in Year 2023. Over to you, Dr. Kini.
Good morning.
Good morning,
everybody.
Dr. Kini.
And thank you, Pakistan Live, for this opportunity. I'll be talking on best strategy for left main bifurcation in 2023. I'm Dr. Kini, Director of the Cath Lab at Mount Sinai in New York. So left main bifurcation stenosis is about 5 to 7% of the cases that we see. More than 80% of the stenosis involves the left main bifurcation. the largest coronary bifurcation because the reference diameter can go anywhere above 4.5 plus or minus 1 millimeter. The left main length also varies from 10 millimeter plus or minus 5, and distal bifurcation angle, which many people consider is important, which is considered 70 or more. Continuous plaque from left main into proximal LAD about 90%, then into circumflex 60%, and from left main to both, which is Medina 111, is about 60% or so. So evolution of left main bifurcation technique over the years. If you see here in 2013, we started with the DK Crush 3, which showed DK Crush was better than Culotte in two-stent technique. Then Culotte was better than the TAP technique in BBK2 in 2016. DK Crush better than provisional stenting in complex lesion in the DK Crush 5, which I'll be discussing a little bit later. And then provisional, which is equal to two-stent technique, which was shown in EBC main. So DK Crush mostly done in China, the others are done in Europe. What really has not been tested was DK Crush technique with the mini crush technique yet to date. So most of the people discuss the DK Crush 5 trial, which was a combination of DK Crush technique to provisional stenting in left main bifurcation. What was important, if you see here, about 482 patients were part of this trial, and 40% was IVUS guided. They used what is called as a definition criteria of a definition trial, where mostly complex lesion. That means if you had left main distal two vessels, the LAD as well as circumflex had lesion, there was calcification, the length as well as the angle, all of this were considered. If more than 2 of the criteria was there, was complex, otherwise was called simple. And what they did was, compared to provisional with the DK Crush, if it was complex lesion, definitely two-stent technique using DK Crush did better. Now, very important, what we learned from this trial was bailout stenting. So 47% of the patients in provisional stenting, that if you did single stent, 47% of the patient required a second stent because of suboptimal result in main vessel stenting. If a complex lesion underwent a simple single stent technique, 38% of the patient in simple as well as 64% of the patient who required second stenting in a complex lesion if they went to provisional stenting. What also they saw is that if you did bailout stenting in true bifurcation lesion, then the outcome was poor. So essentially saying that if you have complex lesion, try to do two-stent technique. Otherwise, you will have poor outcomes. So at 1 year, what did we see? That the target lesion failure was higher in provisional stenting, mostly related to MI or stent thrombosis. And at 3 year, not only was there a difference in MI as well as stent thrombosis, even TLR was higher if there was provisional stenting. So that is the same point that we learned. What was the EBC main? In EBC main, they compared two-stent technique, which most of it, 53% was Culotte and 5% was DK Crush. And other they did was provisional stenting. In that, if they needed something, they did TAP technique. So 53 and 32%. No difference between any of these techniques. So there's a difference between DK Crush and EBC main. Essentially, DK Crush used complex lesions compared to EBC main. That may be the reason we never saw technique. Definition criteria I discussed a little earlier, and very important is the same thing. Major criteria, minor criteria for left main, non-left main. Essentially, Medina 111, stenosis greater than 70%, length more than 10 millimeter, or minor criteria are very small. So this, what did, if you see here in the definition, this was non-left main. To be clear, DK Crush was used in 78% and Culotte in 18%. And most of the difference you saw that planned stent technique was better, two-stent technique compared to provisional, and differences was seen at 1 year. At 5 years, 3 years, there was no difference in outcome. IVUS was used in about 27% of these patients here. So again, the same, that if you have complex lesion, try to do 2-stent technique. And if it's a simple lesion based on this definition criteria, provisional stenting is okay in this patient. Then comes, we always discuss which is a better technique, and everybody do talk that DK crush for most of this technique probably is better. And if you see here in this paper, the patients who experienced cardiac death in unprotected left main PCI, they were grouped into tertiles according to the operator experience. So very, very important. Who were these people? So operators who were high volume, who considered more than 24 cases per year. These are the people who operators did a better job. If the low volume operator actually had a poor outcome. So very important, who should be doing this kind of complex procedures in this day and era. Then is imaging very important? So there is multiple trials as well as data showing that intravascular ultrasound in 2014, about 50% of the cases are done using ultrasound. And if you used ultrasound, imaging versus no imaging, definitely the outcome is much better at follow-up in these patients. So having all this data out there, intravascular ultrasound has become the part of the current guidelines. So IVUS, which has been 2A for procedural guidance of complex coronary stenting. So left main falls into complex coronary stenting here in the left main. You can also use OCT if not for IVUS in some of these cases, except for ostial left main disease. So pre-lesion assessment, which will be plaque morphology, stent sizing, and landing, as well as post. Most important in the post is optimization. So IVUS use has been shown here in majority of these trials. Both there is 2A even in European guidelines. So this is a recent paper that just came out, which is saying that if patients with left main with a syntax of less than 22 is appropriate to undergo PCI, left main with syntax between 23 and 32 is 2A. But again, in the guidelines, DK crush has been part of it with 2B for this kind of cases here. So the same thing, the central figure, which is saying that baseline complexity assessment based on angiography or IVUS. Same, if the patient has complex lesion, consider 2-stent technique. If there is no complex lesion, you can do provisional stenting, and then you consider crossover. And when do you consider crossover? That your side branch has a TIMI flow less than 3, there's a side branch dissection, or you have side branch stenosis greater than 90%, which can be confirmed by IVUS, and in rare situation, they are saying you can do FFR or IFR. There is no study to prove that FFR, IFR of the side branch, which actually was DK 6, did not show that there was any difference, but somehow it has made it to the guidelines that you can do FFR, but there is no study to prove that, and intravascular imaging is a must. So Mount Sinai, we do a lot of live cases. We did about 48 live cases in 2022, 20 bifurcations. Of that, about 10 were left main bifurcation, because majority of the people would like to see how bifurcations are being done. And this is the case of left main, where we did intravascular imaging, showed the disease in the distal left main, ostial circumflex distal left main. Also, you can see there is a nodular calcium. We did rotational atherectomy followed by 2-stent technique, and this is how the final result of it you see here, with good optimization even on the IVUS. So this is the future of bifurcation in 2023, which we are working on using AI, where you, after doing angiogram, there'll be automatic QCA detection, followed by the apps that we have created, which will tell you which particular technique is better, and a step-by-step guide for treatment of this complex PCI that we are talking about. So in summary, ladies and gentlemen, complex distal left main bifurcation planned 2-stent technique is superior to provisional stenting. high volume and experienced operator for left main PCI has better short and long-term prognosis, and pre and post PCI intravascular imaging assessment is recommended for complex coronary stenting. AI-powered cath lab is closer than ever. Combining our experience in complex bifurcation lesion treatment, we will create an AI algorithm to automatically analyze bifurcation lesion and use our educational work to recommend technical devices. So thank you for your attention. We have multiple apps, Bifurcate, for which is that 3D animation that you can see here. All these are free to be downloaded. You can go to cardiologyapps.com and see several other apps that we have made for all the interventionalists. Thank you.
Thank you. So what she told for the younger cardiologists, this Bifurcate, it's a very good app, you know. My question, obviously we have discussed, she has discussed all the bifurcation strategies. My question to Dr. Chen, what about the Chinese experience for the provisional stenting using the jailed side branch kissing balloon technique? The jailed side branch technique for provisional stenting. What's your experience in China?
Yeah, almost from 5 years ago, jailed balloon became.
Can you speak closer to the mic? Yeah,
So
thank you.
Almost 5 years ago, jailed balloon became popular in some Chinese centers, but not too much. But in China, you know, this year we just published the first guideline for left main bifurcation stenting. This is the first guideline from China. We summarize all the international data and to provide more interesting cases. But personally, from my personal opinion, I don't like jailed balloon because there are many problems regarding the jailed balloon. So I still prefer jailed wire. Thank you.
Thank you. So now, you know, you have been a wonderful audience. Now I'm going to hand over to this podium to the second moderator for the session, and that's none other than Dr. Bashir Reeve, who is also the course director for this Pakistan Live 2023. So over to Dr. Bashir Reeve to take you to the second half of this first session. Thank you very much.